All right, everyone. Today, we're diving into an organism that is, a perfect case study for the challenges we face in the modern microlab, Paenibacillus chibensis. It's definitely not your everyday isolate, but when it does pop up, it really makes us pull out all the stops and use every tool in our arsenal. So, let's get into it.
Now, just for transparency, all the information we're covering today was pulled together using a deep search of the current literature. If you want to go straight to the source and check out the primary data for yourself, the complete notebook with every single citation is linked for you to review.
So here's our game plan. We're going to follow the journey of this bug. Right from that moment, it shows up unexpectedly on the bench. Then we'll tackle the puzzle of actually identifying it, explore why the exact species name is so critical, navigate the tricky landscape of treatment, and finally, wrap up with how we stop it from spreading.
Let's kick things off with a scene we've all experienced. You've got a weird organism growing in a really critical sample, and the first question that hits everyone's mind is always the same. Is this the real deal, or is it just a pesky contaminant?
So, picture this. A gram variable rod shows up in a blood culture. This is where it gets tough, right? Because Paenibacillus chibensis is literally everywhere in the environment, soil, water, so it's a classic suspect for contamination. But you can't just dismiss it, because making that wrong call could have some really serious consequences for the patient.
Okay, so how do we figure out what this thing actually is? Well, with Paenibacillus chibensis, your traditional methods can send you down the completely wrong path. This organism is a fantastic example of why our field has moved away from just looking at phenotypes and now leans so heavily on more advanced tech. There's a really clear pecking order when it comes to getting a solid ID here. The gram stain? Forget about it. It's notoriously unreliable. Biochemicals? It's a total mess of conflicting reports in the literature. And that's exactly why we need to trust our more advanced tools. MALDI-TOF is a massive step up, giving you a correct species-level ID more than 80% of the time. But for that 100% definitive answer, 16S RNA sequencing is still the undisputed gold standard.
And this slide right here, this shows you the problem with biochemicals in a nutshell. I mean, the literature is all over the map on the most basic characteristics. Is it a facultative anaerobe or a strict aerobe? Is it indole positive or negative? You'll find papers arguing both ways. It's no wonder our conventional ID systems just throw their hands up in the air.
So why are we making such a big deal about getting the exact species name right? Because when you're talking about the Paenibacillus genus, you're not just dealing with one kind of bug. You're dealing with a family of organisms that have vastly different clinical stories.
Just look at this contrast. It's night and day. On one hand, you have Paenibacillus chibensis, which tends to be an opportunist in immunocompromised adults. But on the other hand, you have its relative, Paenibacillus thiaminolyticus. In newborns, this species is a high-consequence 5-alarm fire pathogen. It causes severe sepsis and meningitis with a mortality rate around 17%, and, for those who survive, absolutely devastating neurological damage.
And to really hammer home how bad that neurological damage is, get this. About 65% of infants who survive a Paenibacillus thiaminolyticus infection are left with hydrocephalus and need a shunt for the rest of their lives. This is exactly why reporting Paenibacillus species just doesn't cut it. The difference between chibensis and thiaminolyticus can be the difference between a manageable problem and a life-altering emergency. All right, so you've nailed the identification. Now what? How do you treat it? This is where it gets really complicated. There are no official guidelines from bodies like EUCAST for this genus, and to make matters worse, it's packed with intrinsic resistance.
This chart tells you everything you need to know. Ampicillin resistance is nearly universal, sitting at over 95%, so your standard beta-lactams are off the table. And vancomycin, our usual go-to for gram-positives, shows resistance in a solid 20 to 30% of cases. It's just not a reliable bet. The bottom line is you absolutely have to perform susceptibility testing on every single clinically significant isolate. No exceptions.
Since there are no specific guidelines, we have to fall back on the fundamental principles of good antimicrobial stewardship. And you know the drill. Get those cultures before starting antibiotics, tailor the therapy based on the AST results you get back, and focus heavily on source control. For a lot of these infections, getting that infected line or catheter out is every bit as important as the antibiotic itself.
Now for newborns, the stakes are just so much higher. The standard empiric therapy for neonatal sepsis, ampicillin and gentamicin, is almost guaranteed to fail because of that sky-high ampicillin resistance. Case reports have shown that drugs like meropenem can work, but we're often talking about very long courses of treatment. And there's this really interesting hypothesis out there that since Paenibacillus diaminolyticus chews up thiamine, supplementing with thiamine might actually help reduce the neurological damage. It's an area that definitely needs more research.
So this brings us to a huge practical problem for us in the lab. How are you supposed to report susceptibility results when EUCAST doesn't give you any species-specific breakpoints? You can't just report the numbers and leave the clinical team hanging.
The key here is to shift our mindset from just providing an S, I, or R to taking on a more consultative role. We should be reporting the actual MIC value and then adding a comment just like this one. It explains the situation clearly and recommends a consultation with an infectious disease specialist. It completely transforms our lab report from just a piece of data into a vital piece of the clinical decision-making puzzle.
And finally, let's talk about how to stop this thing from spreading in the first place. Because it's a spore-former, Paenibacillus chibensis poses a major infection control challenge, very similar to what we see with Clostridioides difficile.
This slide shows something that every single person working in a healthcare setting needs to burn into their memory. Alcohol-based hand sanitizers do not kill spores, period. Neither do most of our standard hospital disinfectants. For Paenibacillus, you have to go back to basics, physically washing hands with soap and water to remove the spores and using a sporicidal agent like bleach to clean the environment.
So, the infection control measures themselves are pretty straightforward. Standard and contact precautions, a single room if you can, and dedicated patient equipment. And here's a final thought. Even if you think an isolate is just a contaminant, its presence should be a warning bell. It tells you that you have a highly resilient, spore-forming organism in your facility, and it's probably a really good time to review your cleaning and disinfection protocols.
So, if you only take one thing away from this explainer, let it be this. For the genus Paenibacillus, getting that species-level ID is not just an academic exercise. As we've seen with the dramatic difference between chibensis and thiaminolyticus, it's a clinical necessity that directly and profoundly impacts patient care and outcomes. And that's our look at Paenibacillus chibensis. If you found this briefing useful, please subscribe for more deep dives into clinically relevant microbiology. And we would genuinely love to hear about your own experiences with this organism, so please share your stories and feedback in the comments below. Thanks so much for watching.